Hey, everybody. Welcome to In the Know with Nina. I'm your host, Dr. Nina Crowley. I'm the Director for Clinical Education and Partnerships at SICA, where we partner with healthcare providers to offer body composition solutions. Today, I'm joined by Dr. Monu Khanna. She's an internal medicine physician and board certified in obesity medicine, and she's a new fellow of the OMA this year. She's currently working at the VA in St. Louis. So thank you for joining me.
Thank you, Nina. I'm so
So
proud to be here. It's going to be a fun talk.
it is, yeah. And so we first connected at an OMA meeting. So I thought it would be fun to kind of have you back because we're about to have a new type of OMA meeting. The Obesity Medicine Association is trying a new summit style this fall, and it's actually going to be in Charleston. So right here where we're based. And so I really was excited to see your name on the list, giving a talk about women's health and the gender gap. And so I thought we could pick your brain a little bit before the meeting and get people excited that are going to be there. And for those who are not going to make the meeting, give them a little sneak preview about what you're going to be talking about.
Yeah, of course. I would love to.
So why don't you give me a little bit of a sense of what the talk's going to be about, and maybe some of your kind of your top line points about women and the gender gap. And I know for me, it's been an interesting application in body composition, how, really the women and men's health have been very different through menopause. And there's all sorts of different kind of ways we can tackle that. But I think, that's a good place for us to start.
Sure. And as you're aware, this year OMA is starting something new. And instead of having two annual conferences, we kind of wanted to have one annual conference, which is the larger event where we have all the attendees come in, and a smaller, if I may say, more intimate, more focused group where we can focus on case discussion and a certain chronic medical disease and how it kind of correlates to obesity. So the intent was to create more conversation about obesity, how to further the conversation, how to make it more applicable for our, professionals who are working there, private practitioners, primary care physicians, and specialists who need that extra education and learning. And as you're aware, OMA provides a lot of good content, each time. I think this year when we met at Denver, there was a session where people were sprawled out near the dais. We had 1,500 people. So all of that is great. Coming to my talk, I'm really excited about it. So the topic is that I'm going to be focusing on is crossroads in women's health, how the gender gap affects women with obesity. And this is something very personal, because we see it as physician providers. We see our women patients struggle so much, struggle not necessarily, in only in obesity, but in general. I think over time, a lot of times we have dismissed what women patients say. Traditionally, historically, if you think about it, when we were enrolling patients for research studies, it was usually the patients who were institutionalized. So in the prisons, in certain ethnicities and races. And over time, and I genuinely believe that it may have started with some good intent that, let's not hurt the unborn child. So let's try avoiding enrolling women of a certain age group. But over time, I think what happened was that this kind of snowballed into something which initially was started as something to protect women, but it ended up endangering women in a certain way. Because now, basically, premenopausal women, who any woman who's of childbearing age, was not included in studies because they didn't want to have a woman who was pregnant, lactating, all the hormonal issues. And it was very easy for us to kind of assume that what works for a man's body works for a woman's body as well. We wanted to generalize very quickly. So that has started to show so many repercussions in today's world. We know that all the cells in a woman's body, it's not just the hormones or the reproductive organs that are different for men and women. Each cell in a woman's body is an XX instead of an XY. So that starts to impact the problem of how drugs are processed, how drugs are metabolized, how women carry their weight differently, how their body composition is differently, how they have a different physiology, and that kind of starts to affect their risk for certain medical diseases, their risk for obesity, their risk for diabetes, their risk for certain cancers. So it's a very interesting topic. And as I'm working on my slides and doing a deeper dive, each day I come up with some article which just kind of opens my eyes and makes me realize that we have to pay more attention to this. This is very important.
Wow, that's really insightful, and I really can't wait to hear this talk. So, tell me a little bit more about, you talked about how the disease manifests differently, and we're talking about, all these different conditions related to obesity and in obesity specifically. So, tell me a little bit more about, what you mean by that, and how the disease manifests differently.
So yeah, so same medication, same disease process is presenting in different ways in a man and a woman. So for example, even if we were to take something simple or not something simple, it's actually very complex, like insulin resistance or diabetes. We know that the physiology of women as they go through menarche and pregnancy and menopause, these are physiological stages in a woman's life when they are going to have insulin resistance, which means these are the times when women are going to put on weight for certain reasons. They are going to have decreased insulin sensitivity. They are going to be at higher risk for developing prediabetes or diabetes. And on top of that, when you layer on, maybe back to back pregnancies or certain socioeconomic traits or socioeconomic determinants of health, which are affecting the woman's access to care or access to good quality food or green parks for exercise or leisure activities, all of that starts to compound. These are things that a man never deals with. So a man's physiology is different. They do not go through those hormonal cyclic fluctuations. And that's why women end up with a much higher percentage of obesity and diabetes and, problems concerning that. Heart
Do you
disease, the biggest leading cause of death in both men and women, it presents very differently, different presentations. So the typical symptoms of jaw pain, chest pain, sweating, we may not have those symptoms in women. It still is the leading cause of death in women, even in the US today, because women present very differently. And because they present differently, and all the studies that have been done have mostly been done on male patients. So when we have a woman complaining of chest discomfort or fatigue and presents to the emergency room for evaluation, it may not cross the mind of the ER physician that this could be a presentation of underlying heart issues because she's not meeting the typical signs and symptoms of excruciating chest pain, elephant on the chest, and those kind of symptoms. So, over time, we have noticed in medicine, women are diagnosed less, they are treated less for heart disease, and 1 in 7 women are turned back away from the ED in the middle of a heart attack. So
Wow.
it just kind of affects their levels of mortality. More women die of heart disease. They get less standard of care, whether it's aspirin, statin, or the blood thinning agents. Over time, we have noticed that women are having worse outcomes as compared to men.
Hmm. And so you talked about the percentages, in obesity. I don't know them off the top of my head. Maybe you do, but I know in the treatment realm, maybe not people who have obesity, but in people who are seeking treatment, I know that that's traditionally been around 80% of people seeking obesity treatment, at least in the surgical program I was with, were female, and I think that's a very so that kind of adds. I don't know. Maybe that's biological access to care. There's some social stuff in there too. Do you have any thoughts about that? The prevalence of obesity in women versus the treatment seeking population?
Yeah, I wouldn't know the exact numbers at the top of my head, but I know, even in daily practice, we see a lot of women who have just been suffering along because we may have been shelving out the same outdated information, eat less, move more. We now know that that doesn't work. We know that this is a complex chronic disease. There are multiple factors at the basis of this. There could be hormonal issues, there could be insulin resistance, there could be inflammation in your body, there could be other reasons why you are retaining unhealthy weight or the way you're carrying your weight. And these factors are different for men and different for women. But if we don't listen to our women patients, then sometimes, even though the woman is having a cardiac event, because she doesn't fit into the typical symptoms of what a man would present with, her symptoms are regarded as atypical or kind
Mm,
of unknown or inconclusive, and her complaints, her concerns are dismissed. I think that is important to look at, because just as with obesity, when we are talking about weight, when we are talking in a sensitive way about weight management, if we are not listening intently, we are going to miss a lot of clues that the patient in front of us is providing. Maybe they're talking about, adverse childhood events that affected them, trauma. Maybe they're talking about some eating habits, emotional eating, nighttime eating, binge eating disorders, which, if we are not hearing them carefully, we are going to miss those clues and we're never going to be able to reach to the root cause of the problem.
mm,
So, yeah, it's just so many things thrown in together that it's important for us to slow down as providers, to pause. And just the way I teach my residents, that if you listen intently, if you listen with genuine curiosity, the patient is going to give you the diagnosis themselves, because
mm.
you just have to have that listening ear.
That's a good point. So, how do you, I mean, listening, intense curiosity, I think those are actually really super important. We can't underscore that enough. What other, recommendations do you have for how obesity medicine or even primary care should be kind of approaching their female patients differently?
As I'm reviewing all this information and collecting my thoughts, I think the one thing that really stands out for me is we cannot dismiss what our patients are saying. We have to believe them. When they come in with a complaint, just because it doesn't fit into the textbook description of a certain disease or disease manifestation, there actually is pain and discomfort. Okay, if that doesn't fit into the typical criteria for chest issues or heart issues, what is actually causing it? We have to keep pushing that envelope, because if we are not going to believe our patients, who is? And they're going to stay untreated, undiagnosed, uncared for. So I think we really all of us have to start from listening closely and not jumping to assumptions that, it's very easy for us to kind of dismiss anybody, or to, land up to a certain judgment, or as JFK said, it's very easy for people to have the comfort of opinion without the discomfort of thought. So we're ready to
Mm.
latch on to somebody's good idea, but we don't want to process it ourselves and see whether does it hold value for us, does it hold value in this situation, yes or no.
That's a good point. So, I thought, maybe talk a little bit about perimenopause, menopause, how that's impacting women, because again, I think a lot of, how this interacts with obesity is we hear so many things out there in, the public or on Instagram, or, seeing people sort of talking about hormones. I think there's a whole lot of maybe misinformation out there and just confusing information. So how does that, kind of come to play for women, and then even thinking about for obesity and even how it impacts their body composition.
Right. So menopause, another difficult time in a woman's lifetime, because with all the hormonal fluctuations, and as I like to explain to my patients, as the protective effect of estrogens wears off, because of that hormonal change, your risk for heart disease goes up. Your
Mm,
cholesterol patterns are going to change. You're going to have less insulin sensitivity, which means you're going to have more truncal adiposity. You're going to have more unhealthy fatty deposition, especially around the belly area. On top of that, if you're adding, mood swings, night sweats, fatigue, irritability, that is a difficult time in a woman's life, and it doesn't have to be. A lot of times we feel that women, while they are in their childbearing age, they are getting the top care, prenatal care during their pregnancies, and kind of as menopause comes in, they start to feel that they are not getting the top level of care. If you think about it, 40% of a woman's life is spent in menopause. So that's a good chunk of a woman's life, which we can still add quality to. We can still add good relief of symptoms if she is eligible, working our way towards hormone replacement, because that can mitigate a lot of those symptoms, that can help with some of those changes that are going on the internal milieu of the woman. And then there are, off the counter symptomatic treatments as well available, which can help with symptom control, not necessarily the root cause. So there's a lot that we can offer to our menopausal women, because as you see with Sika, we can see very significantly that as women go through menopause, their body composition is changing. They're going to have a higher percentage of fat. So unless we start to work on it, we are aware of it, we are unable to solve that and address that. And then, as the menopausal woman grows older, goes into sarcopenia, where there's more wasting, you're losing muscle. As we are all aging, we're all going to lose more muscle, which makes treatment of obesity more difficult. So, if we're able to set up the woman with the tools that she needs, with the right education, information, and support, I think she can have a better outcome. As you might be aware, women outlive men by a couple of years. And that has traditionally been the case, and that's reflective in our society. So, most long term care patients are women because they have outlived most male family members. It's kind of sad if you think about it, that the woman who was the center of the family, caring for everybody, caring for the juniors, the seniors, when she ages and when she is needing support, there is nobody there to help her. And she's
Mm.
kind of committed to long term care. So these are things, being a rehab doc in the past, that's something that always stays close to my heart. It used to just hurt me to see so many women in the nursing homes that I used to make rounds in. And so I think we can all, if we work together, we can do better.
So how do you see that? I mean, now with the GLP-1 and the other incretin therapies that are available, has that changed kind of by gender? Do you see more? I mean, is it close to my bariatric population, more women than men seeking treatment? Do you treat them differently in their responses, or how do you manage that?
Yeah, so at the facility where I work, we still are dealing with a lot of shortages. Um, the supply chain has been disruptive, and has not been a consistent way. So we just have been very creative with our use of injectables for our patients. Um, there is a lot more that goes into caring for women patients as compared to caring for men. They have different stressors. Women are probably, even working women who are not just homemakers, they are putting in extra hours of work at home, whether it's creating a calendar for the kids, or dropping them and creating school lunches, or coordinating care, or
Mhm.
volunteering for the baseball team. So a woman is putting in a lot more as compared to the man. In terms of your question with the GLPs and the injectables that are available, I'm not particularly seeing any major difference as of now. But that said, we have not had a lot of consistent supply. I think it'll be something that I will really look forward to seeing how it impacts in terms of weight loss. What is their impact on men and women? How does it differ? The good thing is that the studies done for most of these injectables have been more balanced in terms of their enrollment for men and women. So there have been more women enrollees, more participation of women. So we really know that these medications do create results in women as well. And they have not just been studied on men.
That's a good point. Yeah, I haven't heard too much about, if either gender had, more or less weight loss or different changes in body composition, but I do know, it's important that we are looking at that and sort of seeing where people are at when they start and how we, kind of treat or manage their titration of dosage or, how often we're bringing them back and even, what maybe those nutrition or exercise recommendations may be.
Right. Yeah.
So, okay. Well, so if you had to sum up, I mean, it sounds like you've been doing a lot of interesting research, and I'm really looking forward to the details of the talk. If you had to sort of sum it up, what's kind of a take home? What should we be considering when we're thinking about this gender gap as it relates to our patients' health?
Yeah, for my medical professionals all out there, I would just start to say we have to do things differently because each day that we dismiss a woman's concerns, we have to make our women patients seen. They have to feel that they were seen, they were heard, their concerns were addressed because we are missing out on a lot. And this has been there. This is nobody, not one person's fault. This is a culmination of multiple years of how research was conducted, how mostly men were enrolled in research studies. For that matter, even when you think about, when you're studying up tumors or any kind of cell lines in petri dishes in labs, you have, or mice or lab mice that we are studying and doing experiments on. Most of the studies do not clearly tell you whether the cell line is a male cell line or a female cell line. So, a drug that was used on a tumor that was being studied by replicating cell populations. So, if that medication worked for that tumor, was it a male cell type tumor that the medication worked for? Is this going to be equally effective if there was a female cell and had the same tumor? We don't know. So, a lot of these things, we have to pause the status quo. We have to be questioning. We have to be curious. We have to, because it would kind of be very arrogant of us to think that we know it all and, this is the best that we can do. There's always something out there that we have not considered. And I
Mm,
think that is important for us because there could be many different manifestations of many different chronic diseases. And if we don't look intently, we're going to miss it, which means our patients are not going to do well.
absolutely. And I think as it comes to obesity and body composition, I think, I know one of the things we talk about a lot is the differences between, gender, BMI, ethnicity. It's important that we individualize the care to the person. So that's what I'm hearing
Oh,
from
yeah.
you too, is that person-centered approach.
Oh,
It's
yeah.
that curiosity, it's listening and feeling heard. So it's some basic humanity stuff that we need to be doing, and thinking about how women have been studied and treated differently over the years and how we can do better kind of moving forward.
Yeah, yeah, totally. Because, it all starts with kindness and understanding that there is something to the picture which is not adding, or as we say, the math is not mathing, right? It's not adding up to something. It's what it looks like, it's not what it seems to be. So there is something that I'm missing in the picture. And to be allowing ourselves grace to, delve deeper, not just to stick by the box, push the envelope a little bit, explore outside of the box. Maybe there's something that we haven't countered yet, we haven't incorporated in our thought process. And that is going to be important, whether it's the care of obesity, whether it's the care of diabetes, because diabetes can look differently in a man, in a younger woman, in a postmenopausal woman,
Mm,
and it needs to be treated differently. Because if you're using the same pharmaceuticals and the same approach for everybody, maybe that younger woman is dealing with back to back pregnancies. Maybe the older woman is dealing with postmenopausal insulin resistance. Maybe the gentleman is dealing with adverse childhood events, which are causing a lot of stress, and with his ethnicity, he is at a higher risk for diabetes. So we have to individualize and customize their treatment plan. There's
Yeah,
no broad brushing that will lead to good results for everyone.
absolutely. Well, I really look forward to chatting more when you're here in Charleston. And if you've got, for people to stay connected to you, I know we're connected on LinkedIn. Is that the best way to connect with you?
Yeah, sure. And as you said, this is your hometown. So we look forward to being there and enjoying all that OMA has to offer. And thank you for your leadership, because it's people like you who keep the conversation going and creating awareness. So thank you for what you do, Nina.
Oh, thank you so much. Well, I'll see you soon. Have a great
Yeah.
rest of your day. Bye
Talk
bye.
to you later. Bye bye.